Thank you for the invitation and for this opportunity to talk a bit about how we work around developing and also appraising guidelines and in the Euro-NMD, European Reference Network for Neuromuscular Disorders. So we have I have the chance of having Carmen and Beatriz before me because they explained thoroughly the agree-to process. The agree-to tool is it's a very useful tool to control bias in guideline production, and it's very extensive and very minute in detail, and it takes some time to apply as well. Some years ago, I discussed the use of agree-to for rare diseases for obvious reasons. We have less patients, we have less research, we have small clinical trials, so there are lots of reasons to think about it. And besides the agree-to, we have also a great component in the assessment of the level of evidence of the publications that we use to start writing or developing a guideline. And so as that process, it's quite complex, and we had already a very good experience with the guideline development group of the European Academy of Neurology. We basically adopted their methodology by signing a memorandum of understanding with them. And here you have the two, you have the main article, the one that describes their position in terms of developing and reporting clinical practice guidelines, the one by Alekowska. But then you have also a more recent one where a kind of explanation about what should be and should not be considered a guideline was published in 21 about distinguishing guidelines, the consensus papers, and saying exactly as Carmen and Beatriz were saying, that guidelines should be very precisely evaluated according to the terms and the specifications that they explain very well. I thought it, for someone who was not acquainted with the process, I think that presentation is very helpful. So besides the adoption of the common methodology, we had to have a guideline group, and so we involved a group of core group of guideline participants and guideline appraisers. And it doesn't mean that in this group we have everybody that can work on guidelines in our European Reference Network. Is just a kind of a core group that basically then spreads outside and articulates with other experts to work on guidelines development and assessment. Our patient representative is Michela Onali, a very active patient representative and very knowledgeable. And but we have a few more members, and this is not readable on intention. So as you see, when we develop guidelines or we appraise guidelines, we involve much more members that are not present in this initial table. So and so the documents that we basically appraise in Euro-NMD, some of them are guidelines, and we follow the ERN's guidance for elaboration and appraisal. Some of them are consensus papers, that is very common in our area, and most of them follow some kind of Delphi process. In the past, as you know, it was more of a nominative process where people would basically glued together opinions. Now the Delphi process is a preferred process. So for a very short description, is a process where experts have access to documents and elaborate questions that they want to answer at the end of the process. And then they basically vote on definitions and concepts and options in an anonymous way, and then they discuss the voting between them. And like that, as the process is anonymous, you can basically go back with your opinion, modify your position, agree with introducing other elements brought by others, and that results in new knowledge that would not be possible just from an individual side. The RAND process is a Delphi with another criteria called appropriateness, but I'm not going on into that. And what I think it's important for this purpose of explaining how we work in appraisal and production of guidelines, I want to go through some of the points of the guideline directives on the right that are the ones from the European Academy of Neurology. First of all, we always have more than one patient per guideline, and we try to work with the patient advisory board to get the more adequate representatives for that guideline specifically. Of course, if it's a disease-specific guideline, we try to have patient representatives that have the disease or care for people with the disease, preferably. Then we use the PICO questions, the PICO questions, as are used in any activity in the scientific world, namely during randomized controlled trials. And we need to basically see if the question that we are posing is significant for the patients. So what PICO stands for is P for population. So we are going to discuss a treatment for a certain disease, for instance, and we need to decide if we are going to discuss the patients in adult age, in pediatric age, because usually the guidelines are frequently not the same. We need to discuss the intervention that we are going to propose in the guidelines. So, for instance, we need to know from the evidence present in systematic literature reviews and papers if giving this treatment is beneficial for patients. And we need to have a control group, and that's what the C stands for. The control group may be an historical control group. So when we do natural history studies, it's exactly to know what usually patients with that disease go through. Or it can be an existing life control group with the same condition, and that are either not treated or treated with placebo. As you know, that's the way to avoid bias from the side of the patients receiving some kind of treatment. And of course, all that I have said in the development of the PICO, the O is for the outcomes, and the outcomes are very important because the outcomes need to be validated by the patients. Imagine treating someone for lowering the blood pressure, and you can conclude that with drug X, you lower the blood pressure by 20%. But there are two aspects that we need to consider when we look at that number. One is the clinical side, meaning if you lower by 20%, are you putting the blood pressure of the patient in normal range or not? Because 20% could be goodish, but it may not be good enough. So that's what we call the clinical effectiveness of the drug. The other thing is the patient experience, because we can lower the blood pressure by 20%, but does the patient feel better or not? Does the patient have side effects that outweigh the advantage of the drug? And all those things are the things that we ask in patient-reported outcomes that are very important also to be considered during the development and appraisal of guidelines. To start a good guideline, you have to have the maximum information. And as Beatriz and Carmen explained, we need a librarian or a data management expert or both, and a statistician to have a proper search through the literature, the search that the example guideline lists in terms of explaining which databases were employed, what expressions were used, how did you go through the papers, and how did you select them, and how did you reach the final amount or group of papers that you want to consider for your guideline development. That is what we call a systematic literature review, but in some cases of these diseases, as I've said, sometimes we depart from different sources of information, like what we have in a registry, so historical information that will help us to see if the patients going through a long-term treatment with a drug do really improve, or it's just something that apparently is positive on a very short term, but has no additional advantage for the patients. So we use observational natural history, but we use also experimental data when we consider interventions, whatever they are. And we need to state very well who did we include or exclude from the guideline development or from the guideline appraisal. And we need to do it in a way that leaves little doubt. And for that, we need, of course, that the papers included and excluded explain exactly what populations, what interventions, what controls, and what outcomes they have. So I already spoke about the effect sides with my example of the drug for the hypertension and the clinical significance as well. We need also to consider the measures of uncertainty. So in statistics, things are not black and white, they are gray, but the measures of uncertainty are the things that allow us to understand what kind of gray are we looking at. So there are results in a paper from a clinical trial that can have a very certain and accurate conclusion and have a very small dispersion of values, and that has a different significance if we have a very large interval of responses and a much less clear conclusion in terms of the efficacy of the drug or of the intervention. And so about grade, I have nothing to say about it because you've just heard everything that you should know about it. But about the evidence evaluation, that is part also of grades as tools that helps with the evaluation of and appraisal of the evidence level. And by that, I mean, it's not the same if you have a paper saying that patient X has been admitted with this condition was treated like that and got better, than to have a randomized controlled trial saying that 100 patients like X have been treated with the drug and compared with 100 patients like X that received placebo, and there is a significant difference between them. And when we have evidence levels, and that's common in rare diseases, that do not allow us to write a conventional guideline, what we do is to go for a consensus process, that is the Delphi that I've spoke about before. And of course, these things are very complex, and other things that we need to think about are the ethical issues. And then again, the patients are fundamental. The patients are fundamental to plan the guideline. The patients are fundamental to appraise the guideline and to evaluate the results during the clinical trials, and also as safeguards for the ethical issues, no matter how many and how good the LC experts we involve in our work. And so that is also important. That is fundamental. And so the consensus process, I've briefly described it. So basically people sit around and give answers that are anonymized. They look at the results, discuss the results, modify the questions, modify the proposals, refine the list of questions and answers, and then they vote until there is an agreement that allows for the recommendations of certain attitudes instead of ours. It has less of strength in terms of evidence than the process of a guideline, but it is very much common in rare diseases, and we are in the process of developing a guideline with the support of the consortium that is here represented today, where we, after the systematic literature review, will go for a consensus process. And then what we do once we have developed or we have appraised the guideline and concluded that it's useful for our patients, well, we put the guideline or the consensus paper in our website, in a page where you can look every document there, or you can search based, for instance, on diseases. So these are initials of neuromuscular diseases, Pompe disease, spinal muscular atrophy, Duchenne muscular dystrophy, etc. So this is a tool that clinicians and also patients have access to, but it's important also that clinicians have a way of rapidly accessing the recommendations that are endorsed, and try to give the best care to their patients based on this.